All right, welcome back. If you just joined us, you're on to Good Morning Nigeria, and time for us to take our second topic for today, which is the global attention on HIV and AIDS and how, of course, we can suppress it and achieve the SDG 2030 goal of total elimination. So let me quickly welcome our guests right here in the studio. We have the Director General, National Agency for the Control of AIDS, NACA, Dr. Aliyu Gambo. Dr. Gambo, thank you for joining us. You look quite different today.
Yes, my pleasure. Today is World AIDS Day.
Kingsley.
Also here with us is the National Coordinator, Network of People Living with HIV and AIDS, Ibrahim Abdulkadir. Ibrahim, pleasure to have you with us on the program.
Thank you very much.
Okay. Beginning with the DG of NACA, Dr. Aliyu Gambo. Let me ask this advisedly, even though it may sound cynical, against the backdrop of other viruses that are causing more havoc around the world. Is AIDS, HIV still an issue?
It is still an issue. And our thinking is that it will continue to be an issue until such a time when we have either a vaccine, which has now eluded us, the scientific community, or a cure for HIV. At that moment, then we can say we've seen an end to AIDS. But for now, all our effort is to contain it, try to keep it in one place, and ensure that it doesn't leave that place. And that's what we are now focused on doing. Keep HIV with an individual that have it, don't let it out of them, and don't let it kill them.
So how do you intend to do that? So what's the global conversation on the strategy?
This is the conversation that you're hearing, epidemic control, 90, 90, 90, 95, 95, 95, and beyond 95, 95, 95, 2030. The aim is, with more people being identified, if we can identify more than 95% of people that live with the disease and give them this life-saving medication to keep the virus in them and to prevent the virus from leaving them to affect other persons, we will reach a stage where we don't see transmission anymore, new infection, and we don't see death from HIV/AIDS because you don't give the virus chance to grow. It is when you give the virus chance to grow, that's when it does the damage. That is when it brings the individual down, and that is the time when it leaves that person to affect another person.
I still would like to stay with you. AIDS has been around now. By next year, that will be 40 years that the international community awoke to the existence of HIV and AIDS, of course, beginning with the gay community, and then suddenly it went on. We know that, not all viruses have a cure. The common cold, for instance, it doesn't have a cure, but there are flu shots. And the one that has paralyzed the world this year, coronavirus, you have all kinds of vaccines that have been developed, and a number of them, of course, are now awaiting approval, and you are seeing the kind of nationalism that is driving advanced purchases. Aside from the measures that have been undertaken over the years to ensure that the HIV virus now, that's the human immunodeficiency virus, is contained amongst those who are there, why has a cure or a vaccine been such an uphill, if not almost impossible task?
Simply because HIV is a different virus. It's a virus that keeps changing its shapes and form, and that is making it difficult for you to aim it and permanently get it. If I can give an example with chameleon. If you see this, chameleon, changes color. It may be green now. Tomorrow when you see it, depending on the environment, it may be yellow or it may be white. So that's the similar way the HIV behaves. You introduce it to something and it studies it. It studies it, now it mutates and block that area where you find it easy to hit it. And because of that, it has been very difficult to find a vaccine for HIV, simply because there are certain things when we look for vaccine, we certainly get them, and those are what we call correlates of infection. For HIV, it's been very, very difficult to determine what these correlates are because, of this change in nature. And that is the reason why it has taken the scientific community over the last 2 decades looking for vaccine in the conventional way, but the answer has not been coming. And we believe the answer to HIV may come in an unconventional way. And that unconventional way is what the scientific world is yet to unveil.
Nigeria is said to have over 3 million people living with, HIV and AIDS in the country. And that's probably the second highest in sub-Saharan Africa after South Africa. Are we still recording new infections? Because initially, before now, the concern was stopping empty city, transmission. How is that doing at the moment?
We don't have up to 3 million people living with HIV/AIDS, but we have close to 2 million. Our prior estimation before 2018 give us an indication that we may have up to 3 million or 3.5 million. But now with what we did in 2018, we now are certain that we don't have up to that number. We have something that is around between 1.7, 1.8, 1.9. Currently, yeah, and we are using the figure 1.8 currently. And we don't believe it goes beyond 1.9. Hardly it approaches 2 million. Yeah.
So are we having new infections? And what is the state with the mother-to-child transmission?
We do still have new infection, and that's why we are every day out there asking people to know their HIV status and do something about it. Because these are the gateway to HIV programs and packages is HIV testing. If you test and you're HIV negative, then you qualify for what we call our prevention program package. And if you test and you're HIV positive, then you qualify for both prevention and care and support, treatment care and support packages. It's important people to understand this. There is no way we can help you. There is no way we can get into you and know whether you need help or you don't need help without you, braving the odds and subjecting yourself to testing. Either you can do it by yourself, at the comfort of your room, you can test yourself and know your status, or you can come to testing centers where they test individual and know. In the first, there is this fear. I don't want to know my status because, a lot of things are going to happen. Stigma and discrimination, and this stigma and discrimination can come from the health worker that even identify the virus in you, may come from friends, may come from family members and the rest. But over the years, I think we have succeeded in fighting stigma and discrimination to a level where now we have enabled laws. We have law that is against stigma and discrimination, and somebody who stigmatizes and discriminates, can be fined or can go to jail or can have both. Yes, we see new infection, but we are also seeing a reduction in new infection, and this is what
among what community? I'm sorry to interject. Among what community?
Okay, among the general population. There are two communities. There's the general population and you have the key affected population. For now, we know that HIV is largely driven in Nigeria. Nigeria has dual epidemic. You have the one that is declining in the general population, which is what we did 2 years ago and what we found. And you have the one that is raging in key affected population. And this is our concern. And that is why we are out in the field the last 2 months trying to find out the size of this key affected population, the services that this key affected population prefer, and how they want us to deliver the services to them. This is very, very important because it is only when we get to identify the key affected population, identify the services that fit them, and how we can deliver those services, we can get to make that a road we want to make, in this population.
All right, Dr. Aliyu Gambo, thank you very much. Now let's bring in Ibrahim Abdul Kadri. Abdul Kadri, what is the situation with persons who are living with HIV and AIDS? Are they happy, or are they? What's going on?
Thank you very much. Basically, people living with HIV are people that are actually living happily, especially today that we commemorate the World AIDS Day. Is a day I think that every person living with HIV feel like today like a bad day to him, because it is a day that people around the world actually converge to show love and care and solidarity as well. So for us, we are happy because treatment is working. People are having access to affordable treatment and care and prevention services in Nigeria.
When you say that people are happy because of the reasons that you have just articulated, we do know that up until recent years, there were issues with access to regular doses for treatment. So where is treatment more readily available now, and at what cost, if any?
One, the ARV commodities are free of charge, number one. Number two, at the time you mentioned in the recent years, actually we had a challenge up to early this year, around February, before the emergence of COVID-19. And the ARV drugs we have is in 3 regiments. We have the first, second, and the third line. So the first line is readily available. In fact, we have more than enough, because it is confirmed during the COVID, people have access to 3 up to 6 month dosage, because we don't know where COVID-19 will end up. And then secondly, it is the second line, which has a global challenge in terms of supply chain, and because also COVID has also contributed, so that has been acknowledged, and also a salvage therapy was actually provided to ensure that those on second line, especially for their combination of lopinavir and ritonavir, is actually being provided, which is also being used around the world to also test the effect of drugs that can actually treat COVID-19. Then the third one is those on the third line, which is actually not available. But as I'm talking to you now, the government of Nigeria was able to procure that drug that has not been readily available, and now is accessible, and people are actually accessing their drugs in our hospital settings.
I know you have enumerated all the good points, but I just like you just to cap up in evaluating national response.
Yes.
When at the peak of the outbreak of the virus or the infection, and the down end, how do you evaluate government response in terms of care, treatment, and of course aftercare?
Good. So in terms of the entire evaluation, actually, I must confess, majorly the intervention is majorly driven by our donor communities, especially the American government through PEPFAR and the Global Fund. We have the government of Nigeria. We also need to give them that credit. President Muhammadu Buhari in 2017 at the UN General Assembly made a pledge to put additional 100 people on treatment, and I am confident and happy to inform you that since 2018 and 2019, he has actually fulfilled that commitment, and government is really investing at his pledge and promise to put people on treatment. So that is available, and so we are happy. So majorly, what we need more now is to focus on counseling, because we have about 1.2 million people that are currently on treatment. But with the good news that the treatment is working and people are achieving viral suppression, but it's actually observed that the number of counseling that we used to have in the campus is actually, it has reduced, And this could be because maybe majority of the donors that are really supporting our treatment program are declining their support for HIV and try to let government to take ownership and to also continue in doing that. So what I just want to emphasize here is that the government should also not focus on just only purchasing the commodities, but to also train more professional people to actually look after these people in terms of providing quality care and treatment services, because we are having new emergence of new infections. Because if I can quote you, we all know HIV started, it was first identified among the gay communities, and we are coming to an end, because for me, HIV epidemic is coming to an end, because people living with HIV are no longer dying like it used to. People are living healthy, happy life. But again, that first community that AIDS was first identified are neglected. And because of the sexual orientation, the country, our religions, as a culture, as Nigerian people actually criminalize some of these activities. But if we really want to end the AIDS, as the DG has said, there is an ongoing survey to identify the actual number of this target community. So we need to really focus on that to also find a way of addressing the rate of infections among the key affected population.
Thank you. Dr. Gambo will speak to that, because earlier he was talking about key segments of the population that will need to be targeted, and you have also now raised the issue of not just culture and religion, but also of law.
Yep.
Because we have a Nigerian legislation that criminalizes that kind of sexual perversion. So how do you marry that with the need to safeguard public health? That's the point that Dr. Gambo will speak to. But I still want to stay with you, Ibrahim Abdulkadri. Is discrimination or stigmatization of persons living with HIV and AIDS still an issue?
Yes, it's still an issue. And but again, it has actually reduced to a reasonable number, because people are really coming out today to disclose their HIV status to friends and family members. So for me, if that environment is not actually conducive, people will not really actually come out to even relate to say that they are people living with HIV. For instance, a young person like me coming out to say that I'm living with HIV, I think is a good development, because we have a lot of young people within my age bracket who are still finding it difficult to even go and access the testing services that is free and readily available everywhere. But again, what we just need to address, I know still at the rural communities, they don't really have much information like before. So we need to really focus on town halls meeting in terms of sensitizing people to actually address some of this. And one of the key areas I also want to highlight is the stigma attached to job. Some people living with HIV, even last 2 weeks, a lady came crying that she has applied for a work, and she was screened and shortlisted. Unfortunately, when they found that she is HIV positive, they had to advise her to withdraw from the program. And she said, why? They couldn't provide an answer to that. But later, it was discovered it is because she was HIV positive. And we are working with the DG NACA to also see how that can be addressed. So these are some of the major things that are emerging. And we also have some from the key population and the key affected population. And the good thing is that by next year, we are also trying to do a kind of survey to actually know the actual number of this HIV-related issue within both the general population and also the key affected population, so that we can have an evidence base to say, based on so study conducted, this is actually what is happening. Despite the fact that we know within the hospital setting, these things are ongoing thing, So it has to be a continuous engagement with hospital management to also see how that can be addressed.
Thank you, Abdul Kadri. DJ, you've heard, there are quite about 3 or so questions,
right,
emanating from what Abdul Kadri has said. And the Kingsley's question to you, how do you marry or mainstream culture and religion in providing public, health service to, the affected community? That's one. How are you dealing with the issue of stigma? That's another one. And then maybe last for me will be suppression, viral suppression. I'd like you to explain that in relation with the new focus, with the new strategy towards meeting the 95 you talked about.
Thank you. Marrying culture, religion, and work. I'm happy to say that we're getting full cooperation of the law enforcement agents. And when it comes to key affected population, we explain to them why it is necessary for us to work with this population, for us to know where they gather, and to have access to them is important. And the key, the law enforcement agent give us that cooperation. Whenever we are having meetings or we are having access to this population, no arrests are made, and there are no harassment, and whatever we need in terms of support is given. And I think also the community also get to understand to some extent that when there is a law in the country, wherever, the law has to be respected. Everybody has his right, but your right begins somewhere and ends where somebody's rights also begin. And if we can have this understanding where we look at each other and say, we have a problem and I need your help, and I need you to have access to A, B, and C. If you can grant me that access and I deliver the message or deliver the services, I think it will go a long way. So far, so good. We have not been having clashes with law enforcement agents with respect to that. The second question is the question that is asking about stigma. Because of the importance of stigma, we've been fighting stigma for the last 15 years. But now what we plan to do as early as January next year is in line with what Abdul Qadir is calling for. We're going to train nationwide individuals that will also train others. This is building capacity, training trainers. And the training will focus on 3 things. It will focus on this adherence that Abdul Qadir is talking about. It will also touch on linkage to care, because it is not good enough to just identify somebody who tests HIV positive without linking that person to where the services are provided. And the third one is this stigma and discrimination. We know we have individuals out there that are trained, but we don't believe they are enough. So we want to train more, and we want to do it in our 6 zonal offices. We have an office in each of the 6 geopolitical zones. We want to get a nomination from stakeholders and conduct this training so that these individuals will now step down the training and continue to train that way. And we'll do it routinely from time to time.
The last question on
viral suppression. The linkage between viral suppression and the goal 90-90 and 95-95-95. If we achieve the 90-90-90, what we are saying literally is that we have 73% of people that have the disease on treatment and they get their virus under control, they don't give others. If we achieve 95-95-95, it only says that the remaining 27, because when you have 73%, you have 27% that are tricks of transmitting this virus to others. By the time we achieve 95-95-95, we reduce that 25% by half, which means about 86% of the people that live with the disease know they have the disease and they take medication and they keep the virus within themselves. By the time you achieve viral suppression, last year in our celebrations of this nature, we launched something that we say U is equal to U. what that means is that undetectable is equivalent to untransmittable. By the time the virus becomes undetectable in the patient blood, we believe it cannot be transmitted, or transmission is impossible. And this is very important for people to know, because today if you test positive for HIV and your wife is negative, you can live a life where you remain with your virus in your body and your wife remain HIV negative for the rest of her life. And you can have children that are free of HIV. So this is what we are calling for people to know and to take advantage of. There is no point hiding or keeping information within you, or refusing to know your status. Because if you know your status today and unfortunately you have this virus, the next line of whatever that is at risk in terms of your family or immediate friend can be protected.
Let's clarify this. I mean, early on, there were all kinds of myths about the transmission of HIV and AIDS. What does science tell us now about the more rapid mode of transmission? I recall, I mean, we say this, it looks more like a joke now. In the mid-80s, around about 1986, when the first incident was reported in Nigeria, there was a report somewhere in Latin America of a criminal who was arrested by the police. And there was suspicion that he had HIV and AIDS. And as the officers tried to bundle him into the cell, he was busy spitting at them. He said saliva was a potent, so they had to release him and let him go. So you also, I mean, there was also the advice about not sharing needles and so on and so forth, and of course intimacy and all that. So what does science tell us now about the mode of transmission? Because again, for persons who are asking about discrimination, look, if you were told that somebody had HIV and AIDS, you wouldn't deal with the person at arm's length. Mm-hmm. You would say, no, whatever the chair the person sat on, you go and disinfect it, don't share utensils and so on and so forth. But it's changing. So, but what do we know now about modes of transmission? And then just take along with that, where is prevalence much higher in the country, urban or rural?
Thank you. So let me begin with that. First is in urban. Simply because of the kind of behavior that put people at risk of HIV, predominantly urban-based. In terms of HIV virus itself, it's a very weak and fragile virus. If you put your hand like this and then I drop fluid with HIV and you rub your hand like this, you kill the virus. And it's not going to go into you, simply because it needs an access. This thing that you see, skin, is a barrier. Mm-hmm. It prevents the virus from going in. But if you have a cut, somehow, the virus the fluid that contains the virus come into contact with your internal body, then the virus can have access. And that's exactly what happened during sexual intercourse. So it is not usually because of the intercourse, but because there is an access there is a cut, and the mucosa there was very thin. It's very thin. And you realize that because of the pressure that is involved in the activity, it usually gives way. So that is the enabler for transmission. There must be some kind of a route or access or an aberration that enable the virus to gain access into. But that's why you find discordant couple. Husband is positive, wife is negative, or wife is positive, husband is negative. Some of them are because of this. It has not come to that stage where the transmission will take place, despite the fact that the individual has it. And there are people that are naturally resistant to HIV. This thing that HIV cling onto when it enters into the human body and get into the cell to do the damage, some people just lack those receptors. So when HIV comes around, it doesn't find something to attach to, it cannot go in, it falls off and dies.
Okay, thank you.
Is there still transmission by blood transfusion? Because that was a very common thing in the past. I mean, Atoash, the famous black American tennis player, had that.
Very, very unlikely these days because virtually most of the blood that I use, are blood that have been collected ahead of time. They have been screened and all the relevant tests are done. By the time the needs arise, this blood that is already banked is taken and given to patients.
Okay, Abdulkadir, what can be done, just less than 30 seconds, what more can be done in terms of strategy to attain viral suppression?
Is adherence. People are taking their medication properly and at the time that is being prescribed to them to take. So once that is achieved, believe me, viral suppression will be achieved.
All right, Ibrahim Abdulkadir, National Coordinator, Network of People Living with HIV and AIDS, NEP1. Thank you very much for joining us on Good Morning Nigeria. And Director General, National Agency for the Control of AIDS, NACA, Dr. Leo Gambo. Thank you very much for joining us.
My pleasure.
All right, that does it for us today on Good Morning Nigeria. We thank you for tuning in. The program, as always, returns 7 in the morning, and that's tomorrow. I'm Kingsley Osadolo. Take care of yourself and be well.
I am Claire Dilabo Abdul Razak. We'll see you tomorrow by God's grace. Meanwhile, stay safe and remember to wear a mask and, of course, obey social distancing rule.